So, good morning, ladies and gentlemen. I hope that you enjoyed yesterday cold evening in Prague, and we will continue with the program of the second day. I'm chairing this session with Hiroshi Nagakawa from Cleveland, and he will start with the first lecture, how to optimize pulse field ablation lesions. Except Peter Peichel lecture, the discussion will be at the end.
All right, thank you, Robert. So I'm showing here's the Cleveland Clinic. I'm talking about how to optimize the PFA lesions. And I think the clinical trial starting like 3 years ago, there are several publications, but to be honest, PFA ablation lesion formation is very complicated compared to RF. RF is simple thermal injury. And a lot of the unknown stuff, there. So, I'm presenting, I don't know very well, okay? Talking about here. So here's my disclosure. So, PFA system for the PBI using a multipolar circular catheter. So several companies produced, and the clinical already, performed and several publications. So this is Dr. Barma. They published the SAC-EP 2 years ago, and they're using the 9 gold circular electrode, and they're like applying 15 volts to 100 milliseconds. And each packet has like 4 burst applications through the 9 electrode. And the first shot, almost always, all gone. No PB potential at the first shot, almost always. The question is it good news, bad news? Depends on, if this is your case on Friday afternoon, this is very good, news, all right? But in terms of the long-term follow-up, good news, bad news, we don't know yet, to be honest. And this is, again, the last year, Dr. Mama, again, they published the SAC-EP for the circulation, actually, the 1-year follow-up data. And like a PF, I'm sorry. I did something wrong. How can I do that? I'm sorry. What do we do? Okay, so just about.
Maybe just try it in.
I want to put a pointer.
Oh, pointer. It's here.
Oh, that's okay. It's complicated. Okay, thank you. So there's 66% 1-year follow-up PFA persistent. 55. I mean, you can say similar or even less than the, compared to the point-by-point RF application, using like ablation index, whatever, some other stuff. And, calculate as a focal ablation. Remember, you have 9 electrodes for application 48 times. This is average. So you can, calculate like 1,728 focal application. That's a lot. But you don't feel because very quick, boom, 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 and you can finish 30 minutes, all right? Procedure time is quite short. All right, I come back to it later, okay? And then we know any circular catheter, it's not easy to make a circumferential contact because the PB osteogeometry more, ellipsoid never get the perfect circular configuration. So more likely you're getting the PB isolation or elimination or PB potential without circumferential contact. Then last 3-4 years we're talking about, we don't need electro tissue contact. And many people told me, especially European famous doctor, Hiroshi, we don't need electro tissue contact. 2-3 millimeter away from endocardium, no problem. Agree, no problem to eliminate potential. But how about the durable, lesion formation? That's actually we don't know, and we are interested for that study. So here's my proposed mechanism: the cardiomyocyte injury by PFA. Okay, we applying the high voltage short period and the increased membrane permeability, or even actually make a pore within the lipid bilayer for the cardiac myocyte membrane. All right, then that's the of course, easily disturb ionic channel. Very easy to produce the conduction block. However, PFA, actually, it's starting pulse field application, starting reversible electroporation. Those membrane repair, it's not going to die. That's people doing the like oncology, gene transfer, make operation, gene transfer, and resealing those pores. So definitely that's the reversible electroporation, which is for us a transient conduction block. It's not permanent conduction block. And then if you induce the dosing, starting at the greater pore, resulting the ATP like a leakage. But as long as the mitochondrial activity preserved, ATP actually for the compensate to production. Still, those are the transient or reversible electroporation. Further increase, now they're damaging a DNA mitochondria. And then that's actually initiating apoptosis. This stage, that's irreversible region formation. If you further increase cell membrane rupture and the tremendous calcium influx into the myocyte, resulting in the contraction band necrosis, swelling, hemorrhage. Okay? So then we starting this project 5-6 years ago. So as we know, the RF ablation lesion size, incidence in pop increasing the contact force, RF power, and application time. So therefore, we developed with Barson's Webster like a force power time index, ablation index, long time ago. And contrast to the RF, actually, it has been reported that PFA does not require the electrode tissue contact to achieve the effective ablation lesions. However, it's not well validated, and we are very interested in studying 5 years ago. So we'd like to determine the requirement for the electrode contact and the relationship between the average contact force and lesion size for the PFA using a beating heart swine model. So starting with the galvanized system, that's a biphasic microsecond application, and combined with a focal ablation catheter, the TAC catheter Abbott, which is a 4 millimeter tip with a contact force sensor. So you can deliver the RF or you can deliver the PFA, whatever you like. So this is published data. We published the January SAC EP. We're using simple study, the 5 swine, RB, LB ablation, and the right ventricle, like a 28 amps. This is the current control system, 35 amps application. The variable is contact force, low, moderate, high, like a 10-gram range low, 20-gram range, 40-gram contact force. And also we examine the no electrode tissue contact, like 1-2 millimeter away from endocardium, confirmed by the ice, as shown next slide, here. Catheter is floating. And so we also watching the contact force tracing. Definitely not touch, but very close, okay? That can happen quite often in clinical setting. And also we're changing the contact force low, moderate, high, up to like 40 grams. All right. And this is the ablation, 2 hours after PFA. This is TTC staining, 35 amps, 18-gram contact force. And this is cross-section left ventricle. Here's the endocardium, epicardium here. And here's the lesion, has 3 zones. We call the dark central zone, histologically showing the disrupted myocyte with like edema and hemorrhage. Consider also the pathologist told me this is a famous contraction band necrosis. All right, that's necrosis for sure. And then next one, we call pale zone. Pale zone means no TTC staining. That's indicating the no mitochondrial activity. Also, the histologically the nuclear pycnosis indicating a DNA damage. Actually, this is the apoptosis zone. This is very unique for PFA. We don't see much for the RF ablation. And then more interesting, look at here. Oh, I'm sorry here. It's not showing very well, but I call the hyperstain zone. TTC stained even more than normal myocardium, indicating the membrane permeability increase. So TTC dye enter to the myocyte more than the normal myocardium, indicating the like a membrane permeability increase, but still mitochondrial DNA activity is intact. This is a famous transient conduction block zone, presumably. This is very unique for the PFA. RF ablation, we don't see, or very minimum. So completely different from RF. But we're expecting a conduction block zone up to at least here, even more, slightly more. So it's different. However, if you're talking about the durable region, we should combine with the dark central zone and the pale zone. But we don't include the hyperstain zone, even though that's area we already conduction block. Make sense? Any question? It's different. So that's irreversible zone. Then here's the reversible zone. Whatever you do, you make a durable region, but surrounded by the broader area, transient conduction block zone. That is the maybe problem for us, okay? And then here's the summary, average contact force versus lesion depth. So 28 amps application, total 1.4 millisecond application time, and the 35 amp, and the total 1.6 millisecond application time. Make a long story short, first of all, increasing contact force from 5 gram up to 50 gram, lesion depth from 2 millimeter, 8 millimeter. And the lower dose is a smaller lesion depth, but most importantly, even 1 or 2 millimeter away from endocardium, we didn't see any lesion. Okay? And we might see small hint of the hyperstain zone, but we don't see any dark zone, no pale zone. Indicative, you might have some transient zone, but there's no durable lesion formation without contact 1-2 millimeter away from endocardium. And they're very significant. So therefore, based on data, if you believe this data, it's important to have a contact force information, or better not to ignore the contact force information, at least for me. Okay? So then this is another one, the Biosense Western version, and the True Pulse, again, the biphasic microsecond application using the STSF Samcool. They call the, you can apply the RF and the PFA, so therefore Samcool, STSF dual energy, they call the new name, but it's essentially the same catheter, 3.5 millimeter tip with a contactable sensor. So this is their recipe, and 129 millisecond application follow the 1 second of period, another one coming. So those things are very minimal, 12, 18, 24 pulse application. I'm not talking about 1,000 application, okay? It's different. And then, here's data. 12 application, 18, 24 application. Again, each group has a contact force from 5 gram up to 50 gram range. Again, increasing contact force, lesion depth, significant increase non-linearly. And also importantly, without contact, again, 1 or 2 millimeter away from the endocardium, we don't see any, durable lesion formation. This is under the review, so I submit the response to review. Hopefully, they will accept, but we'll see. Then here's the multi-regulation analysis, average contact force, number of bursts, and the lesion depth. So increasing contact force, lesion depth increase, and the increased number of pulse also increase for the lesion depth. Then we made a very simple exponential logarithmic formula to best fitting. And the retrospective analysis estimate based on this formula and the actual lesion depth, this kind of accuracy, like a plus minus 1 millimeter accuracy, like a 79%, plus minus 1.5 millimeter accuracy for the lesion depth prediction, 94%. And then we got this formula onto the Carter, and the next study is a prospective validation study for this formula. So on the 111 PFA application, and then or a target or a predict lesion depth, this formula 3.5 millimeter, 4.5, 5.5, 6.5 millimeters. And again, contact force is variable, for low, moderate, high, and very high, more than 46 grams. So all combined. Then, so here's the predicted region depth by the formula, 3.5, 4.5, 5.5. This is actual region depth. I'm proud to show this, data first time around the world. Plus or minus 1 millimeter accuracy, 92%. This is similar to the ablation index we made a long time ago for RF, maybe slightly even better. And they're talking about plus or minus 1.5 millimeter accuracy, 100%. Again, this is a validation prospective study using, for this formula. Okay. Then also we analyzed. This is the before the ablation and after the ablation. Okay. And this is a bipolar 1, 2, and unipolar 1, unipolar 2. Remember, we're delivering a PFA energy from the distal 4 millimeter tip electrode. So this is a post-ablation. You see the RS amplitude significant decrease down to 4.42 millivolts from the 12 millivolts. And then you see tremendous ST elevation due to the injury current. It's a lot. But interestingly, it's quite different from our lab. We see attenuation a lot from the even second ring electrode, and even ST elevation a lot from the second ring electrode, which is quite different RF. RF, you see, RF, amplitude decrease, ST segment elevation from distal ablation electrode, but not second ring electrode, unless you make big region. So then, for example, this is like a predicted region depth 4.6. This is a predicted region depth. Oh, actually region depth 3.4. This prediction is quite good, right? See, like 60 millimeter. But the degree of the amplitude RS segment decrease or degree of ST segment elevation, just first glance, doesn't look like a very good correlation, right? And here's the data. Yes, the RS amplitude decrease, and then for the unipolar, bipolar, and how many minutes do you have already done? Okay, okay. And then the amplitude injury current like this, and the correlation, bipolar amplitude reduction, relationship region depth and diameter, not great. And then unipolar also poor correlation or no correlation. ST elevation also, this is even amplitude change for the proximal bipolar. And this is unipolar. ST segment also poor correlation. And let me go back. And here's the atrial potential attenuation. Like we're making a SBC, IBC intercable region application using the Galaxy system. First application, I eliminated everything. But if you took out, we just delivered a PFA here. Here's the 14 millimeters. Essentially, we eliminate the almost 3 centimeter area. All potential is gone. However, you see the conduction block, but you see the gap between the dual region formation site. And then I'm just going to the last slide. So this is a fair pass. Okay. And here's the case in the Cleveland Clinic. First shot, all gone. All right? Then, if you want, this is persistent AFib patient after the PBI, plus left posterior wall, isolation. All right? We ablated. And the total application time, actually 67 PFA packet. That's actually calculated through the 20 electrode. 67 times 5 application, 20 electrode. 700 focal application. Although this is bipolar, it's different. Calculation may not be fair, but we delivering a lot. Make a long story short. So then, like this is summary slide. Rapid elimination into a cardiac electron was termination arrhythmia. It's not reliable anymore. In other words, we don't have a reliable procedure endpoint based on the EP findings. And then we have to admit lower risk of collateral injury, including phrenic nerve injury, esophagus. I mean, it's not 0%, but compared to RF, it's lower. Then you can say, why don't you ablate more? Push catheter more, all right? But may result in the ALH syndrome. ALH stands for the ablate like hell. And actually, I present like this. You can look at the Twitter X, Nakagawa ALH syndrome. You can see there, my Twitter on X, all right? After my talk, you can try. And then here's the ALH syndrome. Hemolysis, acute renal injury is a problem. And then some other, injury. I'm discussing with the Peter. We might have some the standard myocardium stiff area syndrome, and the heart failure for the BT ablation, and also pro-arrhythmia effect. It's well known for the DC ablation. No much difference DC ablation versus PFA. So in summary, PFA lesion associated with the large area reversible zone, i.e. transient conduction block. During a PFA, elimination the intracardiac electrons and termination arrhythmia are not reliable indicator for the durable lesion formation, and also may not be good acute procedure endpoint. In other words, the false sense of efficacy. PFA without contact information may lead to the extensive ablation to an AL syndrome. That's a false sense of the security. So tailor-made approach using contact sensor, catheter, and exponential logarithm formula to combine the average contact force number of PF pulses to control the irreversible lesion size is recommended for creation, for a continuous transmural PFA lesion or to control ventricular lesion without overkilling myocardium. Thank you very much.
Thank you very much, Hiroshi. We will continue with next presentation by Peter Peichel, her experience with pulse field in VT ablation.
Enable content. Okay, good morning, everybody. Thank you for introduction. Hiroshi had a very difficult task to talk about pulse field because a lot is unknown, and I have even more difficult because I will talk about pulse field in ventricle, where is very little is known. So my point here is to prezentaci. Tak to schoďte a hoďte. So, yeah, musíme to control delete. Sorry. Můžu to smazat. Vy to znova pustíte, víte. Jo, dobrý, už by to mělo být teďka, co teď? Okay, so very little is known. So my task is to give you an overview from a clinical point of view, how you can use the system and what's known. So generally we're dealing with a new energy source, and it's very different. And the questions as a physician, if you encounter this realm, what is different? And there are a lot of differences. So first one is the pulse field works a little bit different if you want to maximize or enlarge the lesion. There are data showing that we don't really prolong the pulses itself. We can, but the maximum lesion, if you want to do, is to repeat the pulse on the same spot. So these are the experimental data showing the size of lesion if you do just one. And you can maximize, it doesn't go more than 4 at the site, but if you maximize and do the 4 applications, similar applications with some seconds in between, you can maximize the lesion to the maximum kind of size. And in this particular study, when the large footprint catheter was used, it was shown that the pulse field can give you the lesion depth about the 9 millimeter, and this is kind of more than the standard STSF, which we currently use as a standard EAS. On the other hand, the RF in this particular system was a little bit even deeper. So the way you use the system is a little bit different. You don't wait long, but you just keep ablating the same site. There is a hope for pulse field to generally be deeper for scar. There are data for that, and I believe we need more to really prove that. So this was studied with one of the prototypes that were used, and whether this is applicable to all pulse field system, there is a question. But generally what it showed that in the normal myocardium, there was not much difference between pulse field and RF. But in the previously scarred myocardium, there is not much, 2 millimeter difference. Maybe clinically relevant, maybe too small, but I believe this is something we need more to explore, and every system should have such a data, because the one pulse field may not translate to different pulse field technology. I mean, nice kind of experiment that may actually point that this might be true is from Jakob Koruf lab, when they did one lesion in the ventricle, they waited to heal up, and then put the catheter into similar location and did an additional 4 applications to maximize the lesion. And it seems that the previously created scar didn't prevent the new kind of lesion development. There was no kind of offset on the side to really kind of show that there is some limitation, or the previously existing scar would limit that. But again, this is something to be proven in clinical practice. So these were the good ones. The bad ones is that there might be some acute effects that we are not used to with RF, and that was already mentioned, and that this may be some significant stunning of the ventricle, because the reversible zone is much larger. So you generally maybe not creating such a large lesions, but you may actually transiently stun a lot of myocardium. There are experimental data showing that just after the pulsing, this was an experiment with pulse field on the septum, interventricular septum in animal. And after doing that, there was a tremendous edema and significant systolic dysfunction, generally saying that maybe the lesions at the end was not that big, but the stunning was prominent. And this is very relevant in patients who have already low ejection fraction. If somebody comes with the ejection fraction of 20% and you stun a large amount of myocardium, you will have no VT, but you may not have contracted myocardium as well. And that's important to mention. Other issue on pulse field is in ventricle is the effect on the conduction system. And this is very important thing, because if everybody who starts to work pulse field realize very quickly that even far away from the conduction system, you can get damage to the conduction system. As was in this study, when in experiment, they did ablation on the interventricular septum, immediately having the AV block. It took some minutes to recover the conduction and 1 hour to completely recover the conduction. And this may be from a far away. And to be honest, from what I've seen in a clinical practice, this is very true. On the other hand, it must say that usually we always never try to ablate directly on the system, always recovered. So maybe the stunning effect on the conduction system is something, then the durable effect on the conduction system is something that needs to be studied more. But generally the caveat here, do not go close to the conduction system with your pulse field if you want to try. This is very important, because you may be unfortunately surprised. And this is the kind of reversible zone that does exist with pulse field, and it's something that we can also use to advantage, maybe in the ventricle. These are the data showing that these very short pulses can do a kind of early conduction block or some stunning of the myocardium, but then very early recovery, which can be used to test whether this particular part is or site is a part of the circle. So something like entrainment, something like to verify that this is the site you should hit hard then. It works nicely in atrial level, at least at my experience. In the ventricle, it's more difficult because there's much more myocardium, and the stunning effect, it maybe applies to very, very near field kind of part of the tissue. So if we summarize the differences, thermal lesion is for radiofrequency. Pulse field is non-thermal lesion. If you want to maximize lesion, you don't wait longer, but you just apply up to 4 times at the site. Maybe there is a better penetration. We need more data, but there is a hope through the scar. In terms of the collateral damage or popping, I haven't seen any popping with a pulse field yet. Probably it's not coming, but there's no fistula yet. But on the other hand, pulse field can do the stunning, which might be not permanent, but in the very sick heart, it can be something very significant. Conduction system damage, definitely spasm is something which is always brought up. I don't believe it's such a big problem, but because it's better to have a spasm rather than thrombotic occlusion of the artery, which is something that also RF can do. The reversible lesion is something that is very true for pulse field. We should be there may be high risk for recurrences because it looks perfectly acutely, but might not be in the long term. But this also gives you potential for the reversible pulses. So what are the clinical experience of this? So it's very early on, and there is a hope to use it because there are multiple potential applications. We can use it hopefully for deeper lesion creation. This is something we wished for to do it safely compared to what we have with RF. If you maximize the RF, then you get into the realm of popping or tissue overheating, and that might be a problem. There are some sites that the RF is limited by physics, and that's, for example, in the coronary sinus, and I will talk more about that. For papillary muscle ectopy, this is very early on, but the general thinking here is it's easier to stay for 5 seconds or 4 seconds, which is the pulse field time for application or energy delivery compared to the very slow cooking with the RF. So there are some data that might hopefully show one day that for these unstable locations, that pulse field, because it's short time application, might be interesting. Epicardial space, this is something pulse field was invented for, or just in the very beginning, people were using it because the risk for nerve injury, phrenic nerve injury, and maybe vessel injury is probably lower. And as was shown yesterday by Vivek, and there are some experimental data on bipolar pulse field, there's just something that also may come. So this is potentials. They are looking interesting, let's say. And if you look in the literature, what is the evidence? Well, what you find is only case reports in humans. So what we can learn from these case reports? Well, not that much, because the good things are published, the bad things are not. So we just know that some things are feasible and there is maybe some potential there. So let me go through what we have so far experienced and what we have used. So we have 2 systems available currently that we can use. Both is off-label, obviously. The first one is Centauri by CardioFocus. It's a system it's a generator that can allow you to use 3 different manufacturer catheters for ablation, and applications that are in a series of pulses which are triggered to the QRS complexes. And this is something which was tested in the atrial fibrillation. Ante Anic was the one that published the Eclipse AF study. But it can be very easily, and that's a nice thing about the system, connected to your cardio system, for example, and you can use it during the procedure. If you decide to pulse field, you can do it. So this is the study that actually made it for us, kind of proof that this is something to really look into it. So this was a non-ischemic patient, non-ischemic cardiomyopathy, multiple VTs, somewhere from the anterolateral basal LV. And when we start to ablate, we didn't really were successful. And when we're looking at these arrhythmias, endocardially, the prematurity was not very great. So this was like, it's the similar kind of timing. But because we had a CS catheter, look at what the distal CS shows. So a lot of fragmentation and the prematurity during these ectopies, which were similar to the VT. So there was an epicardial scar in the anterolateral summit region, which was not really doable from the endocardium, and the pacemap actually you can see. So what we did, we apply in the distal CS, because in the distal CS you're very limited with RF delivery. You go 20 watts. If you go more, you have the impedance rises, some other stuff. And we obviously not ablated only in the CS, but we did coronary angiography before and after, and it worked perfectly for the patient. He had no problem. So we were looking more into it, and there are new data we put together with our colleague from České Budějovice, 12 patients when we did that. And there was 12 patients with the application in the CS for PVC or VT, and most of them had a previously failed ablation, so 75%. The actual success is not perfect. Not everybody can be treated by this. But then we looked what's the prediction. The prediction was actually the prematurity. So if you have a prematurity in your ablation catheter more than, let's say, 20 milliseconds, that this worked. So you have to, if you are very close, I believe, and then it enables you to deliver the full power of the pulse field. So, and obviously there's one part, this is the efficacy, the other part is the safety. So that's always bringing up the spasm thing. And the distal CS, you may say it's very close to the left main, so it may be dangerous. We look at that and we were ablating, and we reviewed the data. It was 2 to 6 millimeters from the main coronary artery, and we never seen anything when we did coronary prior and after. So at least in this small series, it seems to be reasonably safe and something to look at it. So this was actually the good about the pulse field, and in this particular location, I believe that might be something to look for. And also data coming from Ante Anic when he uses the CS application to ablate WPW, similar kind of location, maybe not the distal one, but for the left-sided accessory passing, not going transeptal. So this is something that I believe is going to stick. There's on the other hand, some caveats that you have to be aware if you use these catheters or these new technologies. So this is other patient, which was a terrible patient, hypertrophic cardiomyopathy. She had recurrent storms, and here we did in total 7 ablation procedures because she kept coming back. And the ventricle, it's not because of us, but it's more for a pre-existing disease. Half of the left lateral wall were really sick. And because we were really desperate what to offer, because the heart transplant was not available, we generally used the Centauri to really look for some maybe better penetration into the scar. And we still, despite the 7 previous ablations, we could find the late potentials there, which were very nicely eliminated by the pulse field. But there were also some things that are scary, and this shows in here. So this is the normal conduction, and this is the pulses, a series of pulses, and what it's after is a complete AV block. And this is very scary because when we were pulsing, it was not close to the His, we were somewhere on the lateral wall of the left ventricle. So this would be the His region, and this is the completely opposite side of the LV. So how you can really protect the AV node if you just on the other side. And what's this? This is something with the pulse field does, or we didn't understand that. And it's also credit goes to Alan Bulava, who actually noticed one thing which actually resolved this issue, and it turned out to be very simply an unexpected explanation. So because we're using STSF, despite being a distal tip and proximal rings, there are 2 different electrodes on the STSF, and this is used for magnetic impedance tracking of the shaft of the catheter. The problem is, and the company is very well aware of it, which is they don't say you up front, that if you want to put 2,000 volts into the distal, not to have you have to put some current also into these electrodes, just not to have a short cutting or just frying the catheter inside. So you cannot have these just empty without any electricity, and this is 2,000 volts. So you have to put something about 20%. And if you do so, this one, by luck, ends up very close to the His. You can actually damage. We had 2 patients with transient LBBB and 1 patient with transient AV block. It took 2 hours to recover, but it always, because it's a small electrode, was not durable. But there's something to be aware. If you use this platform with the ST catheter, be sure that because if you do, for example, RVOT ectopy, it may end up the same, that this one or this one will end up close to a very conduction system. And this is something to be just, it's very easy to cover it with the sheet and you're safe, but just to be sure that you pay attention to these small details. Obviously, this is off-label use, but this was very something that we were desperate and we wanted to do. The patient did well 2 weeks after because she had a heart transplant, which gave us the opportunity to really see what the pulse field lesions look like. And this is we're still waiting for the histology. But generally, even after less than 2 weeks, we could see these hemorrhagic lesions. So this is a little bit different. What Hiroshi was saying was 2 hours. This is 2 weeks. Still, there is this hemorrhagic scenes. But this lesion, important thing is the penetration is definitely not transmural. It's, I believe, at the margin of 6, maybe 8 millimeters to the depth. Obviously, this is on a pre-existing scar. So this is something, I believe, reasonable. If you have a pre-existing scar, you can go 6 to 8 millimeter. It's not that bad. I mean, that's quite nice, actually. This is something what we wish for. Obviously, in hypertrophic cardiomyopathy, there is much more way to go to really have some effect. And troponin level, because we ablating the scar, was not that high in this particular case. So this is something, just a proof of the concept that these lesions do exist, that we do some damage. It's a reasonable, and maybe this is something to look for in the future. So this was a single 4 millimeter tip. There's the other technology that is available, and it's Affera, which used a large footprint catheter. Looks like this compared to this much larger lesions. And it comes with the 3D mapping system pump generator, and if you want to use it for VTs, again, it's off-label. This is something you are not maybe advised by the company, but the company provides you a kind of way how to use it. So it's going to use a radio frequency, and because you want to cook well, so there's not 4, 5 seconds applications, but 30 seconds applications where you really want to cook deep in the tissue. But you can also use pulse field. It still is 5.5 second application, and you can repeat it on the side to maximize the lesion. So just a few illustrative cases. I want to show you large cohorts because we don't have it. We just have a few experience with it. So this was a patient, a good patient with correction of transposition of followed. It is a large scar, several operations, several surgeries, a large scar on the lateral wall of the right ventricle outflow tract. This is the ventriculotomy where this apex pulmonary artery. He had also have a transcatheter pulmonary valve. And he had a VT that seems to be nice because it really circulated around the atriotomy, ventriculotomy scar on the lateral wall of the ventricle. And we failed to ablate it because there was a lot of trabeculation there with RF. So we used Affera. And again, when we use Affera, we start to use RF first in the ventricles because that's something we know, and we don't want to really, only if we fail with the RF, then we go to pulse field. And so we use these really big red balls, are the RF lesions. They stopped the arrhythmia, but didn't make it non-inducible. And it was only these smaller green ones, which generally are the pulse field lesions that make it in the final non-inducible. This is termination by a series of pulses. But you may say that these are captured beats, so they may just kind of captured by, and that's what stopped the arrhythmia. And it's important also note here that if you ablate close to this metal inside the heart, this was the pulmonary valve cage of we did, and there was no problem to do so. So this is something to also have more data on, but that was possible to do, and for this particular patient, this worked. Another illustrative case, and which I believe this was one case. The other one, which I believe is also have a potential for future, and it's epicardial pulse field ablation. So this was non-ischemic patient with a lateral scar, and this VTs from lateral wall, and we did map endo, we did the map epi, so this is the sphere 9 in the epicardial space. And when we look at the electrogram, there was nice potentials in the endocardium, but there's a much larger epi. That doesn't seem to be much, surprisingly. And that the explanation might be some epicardial fat overlaying the site. And we first ablated endocardially, but didn't help. And then we ablated the epicardial, despite not that much potentials in the epicardial, just going on the other side of what we mapped from the endocardium when the potentials were. That was the one that really helped. So something like a sandwich ablation, but I believe the epicardial ones that were really meaningful. So they really changed it. And what's nice about the epicardial ablation in this is that there was a quite large branch on the epi when we ablated pulse field close to it, and there was, again, we did coronary prior and after, and there was no change into this. So this is something I believe really nice for epicardial, but pulse field. I believe it's better to have a spasm as a worst scenario rather than the thrombotic occlusion if you ablate with RF. So this is it. So let me conclude that there is very little data, but there is a promise for VT ablation for deeper scar penetration and potentially larger and safer lesions in specific locations like a CS, epicardial space. Definitely, so far, this looks very promising. Obviously, there is a lot of unknowns, like a risk of stunning, higher risk of recurrences if you use just pulse field. We try to use RF first, then only pulse field if RF fails. And obviously, we need more data. Thank you for your attention.
Thank you, Peter. One short question, if you have, because after 2 lectures we are 20 minutes behind schedule. So if you have one short question. Always.
So this accidental
short, please.
Delivery of the pulse field through the shaft electrodes. Is it also true for the electrode 3 and 4? So we also deliver this energy through these electrodes?
I believe so, because as the way I was explained by the company, if you have a 2000 volts in one of the wires inside the shaft of the catheter, you have to put some current into other electrodes as well, because if you have the difference between 2000 and 0, it will just, because the insulation inside is not made. The catheter was never made for pulse field delivery. So you have to put some current into all the other electrodes to somehow decrease the gradient and not to have a kind of too much potential difference between those two. So yes, I believe so.
Okay. We are very late, I am sorry. And the next presentation.
All right, the next speaker is Dr. Ciconte from Milan, Italy, and he's going to talk about cath ablation for cardiogenetic disease. Please.
Thank you, dear Chairman. Good morning, everyone. And thank you to Joseph for the kind invitation. Unfortunately, due to the sake of live cases, I couldn't be able to be there with you. I'm sorry for that. The talk of today will focus on the relevance of catheter ablation to date for cardiogenetic disorders, which are a cluster of diseases that, of course, they predispose us to sudden cardiac death. And they represent actually one of the leading causes of sudden death among young individuals considered healthy with a normal heart tissue, and among whom even autopsies may fail to demonstrate specific substrate and specific structural abnormalities. Most of the cases, they could be related to our current understanding of these conditions, and also by the limitation of our imaging techniques in assessing even thin layers below 1 millimeter. Among cardiogenetic disease, of course, long QT and Brugada, they certainly represent the most important ones, particularly when we talk about supposedly normal heart. And if we start talking about Brugada syndrome, considering the initial description by Pedro and Joseph Brugada, the scientific progress has led to the understanding that behind the COVID type 1 pattern, as you can see here in this slide, there is a substrate. And this substrate is characterized in this purple area, characterized by this late activity. This late activity is located and resides in the epicardial layer, confirmed by this contemporary mapping with an endocardial catheter, an epicardial catheter, showing that the late activity are here in the epicardial area, whereas the endocardium is particularly spared. And these abnormalities predominantly are located in the right ventricle, and in some cases, they might be located also in the left ventricle. The arrhythmogenic substrate in Brugada syndrome is dynamic in nature. We know that is extremely important to map the several, all the epicardium with under also sodium channel blockage in order to delineate and define the whole extent of the substrate. And we know that this substrate is strictly related to the clinical course of the events. So the larger the substrate and its characteristics are directly linked to the clinical course and the clinical manifestation of the disease, as well as the EP inducibility during EP studies. Behind that, it is a cardiogenetic disorder, and we know that pathogenic variants in the sodium channel, we know that they are directly involved into the extent of the electrophysiological abnormalities that we can find in the epicardium, as well as the occurrence of life-threatening arrhythmias and the occurrence of cardiac arrest in these cases. I present here a gentleman of 28 years old at the time of the epicardial mapping. This patient survived a previous cardiac arrest, and he experienced several ICD shocks. This is just one of them. At the time of epicardial mapping, in baseline condition, we can assess the electronatomical abnormalities, and actually you see that with this linear catheter we can certainly identify the cluster of these abnormalities, which are characterized by fragmented and delayed components. In this frozen picture here are more clear and evident. The fractionation and the late activity, which they are located in the outflow tract and anterior wall of the epicardial layer of the right ventricle. And those abnormalities enhance after sodium channel blocker administration. After Ajmalin, you can clearly see that in the area of the black dots, the area of the spots we have tagged at the beginning of the procedure, we can highlight all this late activity that is enhanced if we compared with the baseline substrate. And if you look here in this picture, we have defined the whole extent of the abnormalities characterized by this late activity and fractionation, which is strikingly different if we compare the electrograms outside the substrate area, which are nicely with new normal voltage without late activity in the end. All these abnormalities, they serve as a target for catheter ablation, which aims to homogenize the substrate by covering the entire region of those abnormalities. And what is the goal? Our goal is to eliminate and get rid of all these abnormalities previously identified before ablation, and after ablation we can reach abolition of the late activity within the substrate. This goal is of paramount importance if we think that what is the goal of the procedure that we want to achieve. And the COVID type ST elevation and the phenotype expression of the disease in the COVID type 1 pattern has completely changed acutely after ablation, and this result can be maintained over time. This is the Ajmalin test performed 7 years later, showing that we are not able to replicate the COVID type pattern, but most importantly, the patient didn't experience further shocks. I think we have a delay in the slides. C'è un ritardo. And I move, and I think you're looking, only the Ajmalin. Just a moment, because we have an issue with the connection. And the patient, in this case, he didn't, can I detach and... Tell me if you see now. Sorry for that. We have... Sorry for this inconvenience. Che succede? Ma si collega qui. Io esco e rientro. Adesso la vedi? I'm sorry for that. Let me close the presentation and I try to reboot, or you want to? What about now? Mi vedi? Okay. Maybe I need to go further, but trust me, I had the monitoring of the patient showing that he didn't receive further shock. Sorry for this inconvenience, maybe it was a problem with the slide. But is important, these informations are important because the efficacy of catheter ablation now stands, and we have presented our preliminary data at the time of HRS in 2022, showing our preliminary data on this randomized clinical trial comparing ablation to ICD therapy, and these data were nicely replicated by the Bravo Multicenter Registry, showing similar success rate. Again, these are very important and crucial data. They provide a robust evidence that supports efficacy of this approach in different cath labs. And we have recently submitted our experience with our randomized trial. Again, these are the latest data showing that ablation is able to mitigate ventricular fibrillation burden, showing that the control group continue to experience further episodes of VF, of course. Regarding long QT, of course, I don't want to spend time in describing, obviously, this condition, but we know that the longest is the QT, and this predisposes to torsion de poids and ventricular fibrillation instances. We know, actually, that current approaches, they have demonstrated their beneficial effect in mortality, in reducing mortality and reducing the events. Those are specifically the avoidance of genotype-specific triggers, pharmacological treatment with beta blockers, ICD, and even LSCD. We know, unfortunately, that we might have a suboptimal compliance to beta blocker therapies in some patients, exposing them to breakthrough events. And we know also that those with a particular severe clinical manifestation of the disease in the form of aborted cardiac arrest, they are predisposed to experience further ventricular fibrillation. And here, I present here this lady. She was a survivor to cardiac arrest. She underwent ICD implantation, and of course, she's a long QT syndrome patient. She developed further events. This is one of the shocks delivered by the ICD. And here the 12-lead ECG is showing a QTC duration of longer than 500 milliseconds, again, proving the high-risk feature. The patient was scheduled for epicardial mapping, and these are the characteristics of her epicardium, showing that the entire region of the right ventricle, going from the outflow tract to the anterior wall and the peritricuspid region, is involved in this fractionation, showing fragmented potential, fractionated with late activity, and this late activity might predispose to a slow conduction over there. And in the inner core of this substrate, there are very low voltage signal below 0.5. All these areas served as a target for catheter ablation, and this catheter ablation aimed to homogenize the substrate by eliminating the late activity and eliminating the fractionation, resulting into elimination of those late activity. After the ablation, we could be able to mitigate those ventricular arrhythmias, and surprisingly, we could document the QT reduction from 520 milliseconds to a shortening lower than 480 milliseconds. This patient belongs to the first 11 patients undergoing epicardial mapping, going into and featuring the first publication in Europace, showing that long QT patients, they do have a substrate, and this substrate is characterized by electronatomical abnormalities in the right ventricle, and catheter ablation was able to mitigate those events. The mapping approach didn't stop there, and we have further patients that they underwent epicardial mapping. 4 of them, these 4, we presented them at our summit last year in Milan as live case. Sometimes, if I have a few minutes to, I am going to conclude that sometimes those cardiogenetic disorders might overlap between each other. And this is a patient who survived the previous cardiac arrest, showing a type 1 pattern in all precordial leads. These precordial leads are B1 and B2 in the 2nd, 3rd, and 4th intercostal space, and is showing also an early repolarization pattern in D1 and AVL. Actually, you can also appreciate the right bundle morphology with the left anterior hemiblock. This patient had a SCM5A mutation. The epicardial mapping is showing not only involvement of the right ventricle of the abnormalities, but also left ventricular involvement in the posterolateral wall and in the inferior wall of the left ventricle, always characterized by this delayed and late activity, as you can appreciate here. They represent the target for our ablation, and later in the follow-up, we could demonstrate that the ECG, the phenotype expression of the disease, dramatically changed, not only in V1 and V2, but also in D1 and AVL, showing that the depolarization has changed and the QRS morphology has changed. In the light of this data, those cardiogenetic disease initially thought as pure electrical disorders, they have an epicardial localization, and they could be described as an epicardial cardiomyopathies, and the awareness of this substrate might help us into improve our treatment strategies, and we hope and we may envision that future imaging techniques with more advanced imaging techniques might help in understanding and detect these abnormalities to improve risk stratification assessment. Thank you very much for your attention, and I'm sorry for the inconvenience.
Thank you. We're going to move to the next speaker, and if we have time, we have discussion end of the session. Okay, next speaker, Dr. Hoshini Bordeaux, France. She's talking about the mapping ablation, idiopathic ventricular fibrillation. Please.
Good morning, everybody. Thank you, Hoshi, for the introduction, and I want to thank the organizer for inviting me. So, oops. So my talk is mapping and ablation of idiopathic ventricular fibrillation, and it starts as said by the last guideline, that idiopathic VF is defined by no phenotype. Of course, the diagnosis is based on the absence of a substrate for VF by, of course, excluding many causes, ischemic structural cardiac disease, and primary electrical disease. And you can see on the right side of the slide, you need to do, it's a class 1 recommendation, to do some exams to really rule out something else than idiopathic VF. And when it comes to idiopathic VF, it's about 10% of sudden cardiac death. When it comes to recommendation for the management of those patients with idiopathic ventricular fibrillation, you see that the guidelines actually, of course, ICD implantation in survivor is class 1 recommendation. Quinidine, isoproterenol, verapamil are class 2A when you have storms or to avoid any VF recurrence. And when it comes to catheter ablation, it's a 2A recommendation, especially when you have a trigger that induces ventricular fibrillation. So we've been working on this topic for quite a while, and since this last decade, we've been really focusing on this idiopathic VF patient, and we map 50 patients that survive of this idiopathic ventricular fibrillation. You see that they were quite young, 33 years old, mainly male, 78%. 6 had a family history of sudden cardiac death. And in summary, what we have found is that we have 2 major substrates in this population that was unexpected. One being an abnormal Purkinje activity, and the majority of the cohort had what we call localized myocardial myocardial depolarization area. So I will go through all this. So we first look at the origin of the triggers activity, and as you know, it mainly comes from the Purkinje fibers. And we also look at the substrate by using high-density mapping with the Pentary catheter, mapping the endocardial side as well as the epicardial side. When it comes to the origin of ventricular fibrillation, the triggers, if you look at the Casper registry, you see that they could find in this registry this Purkinje trigger in about less than 7%. And as you can see here, on the upper panel, you have short coupled ectopy, narrow QRS, isolated or inducing ventricular fibrillation. When it comes from the left Purkinje on the right side, you see that the duration of QRS is much shorter. It's when it comes from the left Purkinje, because of the ramification, it's usually between 110 and 120 milliseconds. While when it comes from the right Purkinje, because of the small branch on the right ventricle, the QRS duration is around 140 milliseconds. It's not that short. We know that these Purkinje fibers and this network really provide the perfect medium for arrhythmias. First of all, because it has a complex architecture, as you can see here. It has the intracellular calcium cycling has really unique property with kind of spark within the sarcoplasm. And it can also host re-entry, especially at the distal junction between Purkinje and myocardial fibers. And very nice, I always quote that paper, very nice paper from Heidecker and Taburo in Alabama. They have nicely shown in a dog model that Purkinje was triggering ventricular fibrillation, but was also maintaining ventricular fibrillation. And they proved that by destroying the Purkinje at the endocardial surface using Lugol and they could demonstrate that actually the duration of ventricular fibrillation was much shorter than when you have when you haven't Purkinje than when you have Purkinje. Having saying that, ablation is very challenging because of many things, but especially because you have the unpredictable occurrence of Purkinje triggers. And before taking a patient in the EP lab to do the ablation, it requires documentation of the culprit VPBs to really guide you for the ablation. But as you can see through the talk, there are also some tips to avoid this, because there are ways to unmask Purkinje abnormal activity despite you don't have ectopy at the time of the ablation. So when you have spontaneous ectopy from the Purkinje at the time of the ablation, well, then you are very lucky. So you can basically map as any VPB. Just be careful that it's very subendocardial layers, and it's very fragile fibers, and by doing ablation or even mapping, you can really create a local block. So therefore, your Purkinje fiber that normally you see preceding the local V, as you can see here, when you have a block, of course, it is hidden within the ventricular electrograms. The other way of looking at Purkinjinopathy is to have a kind of repetitive inducible activity during programmed ventricular stimulation. And I will come back to that. And third tips is Ajmalin testing in patients where you have no ectopy. And I will show you that we publish a series of patients where we induce Ajmalin. Here, this is an example of a patient, 40 years old, 10 VF since 2016, failed amiodarone and quinidine. And in last March, in 2024, where I had no ectopy, I had really no idea where I could go to ablate. And the day before, I did Ajmalin test, and you see that after 2 minutes, you start to see these short coupling ectopy. Of course, those one did not induce VF, but they were isolated and indicating that his substrate here was located in the moderated band, as you can see on the morphology here. So when we look at IVF with a spontaneous Purkinje trigger, we could find them in about 22% of cases. As demonstrated here, you have here one patient that have initiation of polymorphic ventricular tachycardia VF, and you see that we are trying to record potential in sinus rhythm, and you see that you have this repetitive activity at the beginning of each polymorphic VT. As I told you, the other way to see this Purkinje abnormal activity is to do programmed ventricular stimulation. So what we do is we use 2 decoupler as shown here on the left side, one on the right ventricular septum and one on the left ventricular septum. And we always try to sandwich the septum and to record these Purkinje more fascicular here, but as we are going further on the distal part here, you see that the Purkinje fibers are really in contact with the local V, indicating that here you have Purkinje mast cell junction. And when we start to do ventricular stimulation, I mean in a very basic way, you see that you can capture here the Purkinje, and you start to have abnormal response. And of course, we make sure that it's not a bundle branch reentry. And when you have VF induction, to be sure that actually the Purkinje is driving the ventricular fibrillation process, if you measure the interval, you see that the I mean, as far as you can count them, and you are sure, you see that the Purkinje cycle are much shorter than the ventricular electrograms, indicating that this tissue is driving the VF process. As I told you, the other way to enhance Purkinje abnormal activity and to unmask them is to use a sodium channel blocker. In that case, it's a Ajmelin test. Here, a series of a patient of 335 patients, where actually we inject sodium blocker to unmask Brugada syndrome in this population, in patients with unexplained syncope. And we were able to, Ajmelin actually induce this short coupling ectopy in less than 5% of cases, and all the tests were negative for Brugada syndrome. So it's really helpful if you want really to help your patient and you have no ectopy at the time of the ablation procedure. And of course, once you have the trigger, that's okay, but if you don't have, you need to provide something to your patient. So we move from trigger to substrate, absolutely exactly the same as for atrial fibrillation. So for the substrate, we are using, as I said, a multi-electrode array, mapping the endocardium and the epicardium. First of all, before what directed our mapping was really the non-invasive mapping here, the CGI. I started that project in 2012, mapping almost 120 patients, more than 200 VF induced. And what we could see is we evidence the presence of the rotors in human VF. I will come back to that later. But interestingly, we could see that following the first second of ventricular fibrillation using this panoramic mapping, mainly epicardial mapping, of course, we could see that the VF cycle length was drastically reducing over time and creating a kind of VF complexity. This is the beginning here on the upper row of the ventricular fibrillation. It's the 250 EGM that are collected. Here it's between 2 and 4 seconds. The third row is between 4 and 6. And you see that the last row is between 6 and 8. And as VF progress, actually you have dissemination of drivers, mainly on the left ventricle, ultimately really shortening the VF cycle length and rendering the VF termination, spontaneous VF termination, unlikely, because the cycle length is really too fast. When we look at the driver, of course, we make sure that during this cycle of re-entry, you can really follow the entire cycle length. And we evidence this rotor, and we say, okay, we will try to focus. This is epicardial non-invasive mapping, reconstructed electrograms. But we say, we just thought that at the site of these rotors, we should find abnormal electrograms using the classical mapping. But before coming to that, in this population of idiopathic ventricular fibrillation, we didn't expect that. It was really a surprise. We found that you had a population where you have rotors that were dominantly lying in the epicardium of the right ventricle. That was the majority of these dominant driver. And 2 patients in this cohort of 50 patients had 2 dominant LV location. And in other patients, you have no dominant ventricle. You see that the rotors were as well in the left or the right. So we could observe a dominant driver in about half of our cohort patient. Interestingly, when we look at the mapping, contact mapping, we were able to see that 76% of these area displaying abnormal electrograms actually co-localize with the rotors, and especially in contiguity with the highest density of VF drivers. And here you see that in the left, electrograms are absolutely normal, while when you are in the vicinity of this rotor, you have all these abnormal electrograms. Of course, they are not the same as Giuseppe have shown, because they are using a decanav catheter, and you see that electrograms are more slopey. But when you use really high density mapping, and we do now use even other mapping, you can really see these electrograms. Here, so when we look at this cohort, we could find in 2/3 of the population, 2/3, localized abnormal myocardial alteration. Mainly in the epicardial, it covers a very small area. It's 4% of the total surface of the ventricle. And the surface area is 14 centimeters square. Here, an example of a female, 30 years old, and you see she has a normal ECG. And while we are mapping, we can see here on this part of the screen these abnormal electrograms, very delayed. Here, another example on the right side. 34 years old, he had VF during sport. We did epicardial mapping, quite dense, more than 6,000 points. And you see that we can nicely see these abnormal electrograms indicating that you have here a substrate. 2 other patients, this one I told you that we had 2 patients from the LV, here it's lateral LV, normal ECG, idiopathic ventricular fibrillation, 50 years old, and you see that the rotor location was located here, and we could see abnormal electrograms in this area. Here, another male, 47 years old, and you see that the location of the driver are mainly located here on the right epicardium, while on the LV you see that there is no driver location. Another example here, a male, 19 years old, had VF while he was having his shower. Normal ECG here on the left, and you see that when we did, this is the only patient with endocardial abnormal electrograms. Here it was on the RV, and you can clearly see these abnormal electrograms. So when it comes to ablation, the ablation aims to eliminate these abnormal electrograms, to simplify this signature, and the mean RF delivery is about 20 minutes, and we aim to ablate these abnormal electrograms or to ablate the Purkinje potential at the site of the triggers, and having this approach in idiopathic ventricular fibrillation, 83% had no recurrence of ventricular fibrillation. So in summary, I would say with this idiopathic ventricular fibrillation, we could find an explanation for idiopathic ventricular fibrillation in about 90% of cases. 22% with Purkinje triggers, and 2/3 for myocardial alteration. However, as you know, in medicine, 100% or 0% never exist. And in 10% of cases, we had absolutely no explanation for this sudden cardiac death. And we think that combining this multi-component approach can be used really to optimize your ablation strategy, whether you look for spontaneous excitability from the Purkinje, whether you look for repetitive activity during ventricular premature stimulation, or if you are able to evidence this island of structural alteration, as shown here. There is also another way to ablate your patient, and this is my last slide, is to do a kind of Purkinje denetworking. I like to call it pruning. It's like a tree. And here it has been published a few years ago already. And even if you have no Purkinje ectopy, you still can help your patient. So thank you very much for your attention.
So, okay, we have 10 minutes for question and answer discussion. Any question from our audience?
I didn't get that. Could
Oh.
you try again?
Thank you. Any?
Questions to
Any
all
speaker?
presentations.
All presentations. Yes, please.
Dr. Nakagawa, I have one question to you. So how comes that the more pressure we apply to the catheter, the more lesion dip we create? So I used to think when we in the contact to the tissue, the field is the same. It doesn't matter whether I push with 10 grams, 2 grams, or 30 grams. What is the explanation for this?
It's simple. It does matter because you deposit energy to the myocyte. Okay, increasing contact cost twofold, actually, mechanism-wise. You are increasing electrode tissue coupling area. All right, like a 4 millimeter tip never have 100% surface electrode area contact to myocardium, but increasing contact cost, contact area increase. So therefore, you applied whatever energy, the percentage energy going to the myocardium increase. All right? Now another issue we call the tissue compression effect. You push, the myocardium compress, then eventually it's favored to penetrate deeper. So it's same as RF and the same as the PFA, or even same as DC ablation. That's a fundamental issue. Okay? Thank you.
Can I maybe also, the question is about the pulse field ablation as well. So do we know how it goes through the fat tissue? So that for radiofrequency allergy, it's one of the biggest obstacles, but what
Actually, to be honest, I don't have enough data my personal data. I mean, I know some publications showing the fat tissue, no problem, scar tissue, no problem. But I know several publications, even I was reviewers on the journal. To be honest, because of my ignorance, I'm not convinced, okay, at this moment. And I had a good discussion 2 days ago with Peter Michael, and also his feeling based on the, still limited experience clinically, but doesn't feel much he's saying the penetration scar maybe statistically significant, but clinically speaking, may not be relevant difference. We don't know yet. Make a long story short, we need more data. Okay.
Hiroshi, I have a question for you. When we use PFA, we shake, of course, membranes, and in that way we destroy the cells. Do you think there is a room for adding something else rather than PFA energy to ensure the durability of lesion, like it was used for decades in cancer?
Mm-hmm.
Any thought on that?
You mean you say let's say you do RF or cryo fast and the PFA, or the other way around?
It can be one way, but a drug or medication can also enhance the durability of lesion.
Okay, so talking about the membrane permeability increase,
Yes.
and then you deliver the anti-arrhythmic medication into the myocyte. It sounds very interesting, but at this moment, way too complicated for me. So again, the PFA, there is the, you can make a durable region. Increasing contact cost, increasing dosing, increasing number of application. You make a greater durable region. But if you do that, also transient zone also increase. Then it looks nice. Fast shot, all gone. It's good news. For me, it's a huge problem. Like we're spending like last 40 years, and everybody, and the electron-guided procedure may not be much meaningful. We're losing the job security for EP doctors. Electron not useful. They just do anatomical approach, but the transient zone big, so they ablate. then result in the LH syndrome. That's I named, but actually we need more data.
Yeah.
It's not simple. All right, thank you.
I agree, yeah. Absolutely. Just destroying the entire atria is not the
Like
solution, definitely.
Or you can do left atria isolation within the
Yeah.
30 minutes.
No left atria, no AF.
But the problem after AF ablation, the contractility is all gone. The thrombogenicity, stroke risk may increase.
Yeah, right.
That's a huge problem.
And just to add to this, I use the, when it comes to ventricular fibrillation, it's always RF. But I found it very interesting when it comes from the moderated band. And you know that the moderated band using, of course, using ice is the optimal tool to really help you to stabilize your catheter. But again, it's very difficult if you go point by point. And using the Affera system, the lattice tip, on the moderated band, it really saves your day. I really found it very, very interesting in that case.
Okay, that's good. Any question?
Maybe we have connection also to Milano, if you have questions to Milano.
Any question?
Do you have connection? Okay, so Milano is no connection, sorry.
No.
And probably
They are ready?
They are not in connection.
Okay, I have a question to you. And talking about it's nicely showing the body surface mapping during we have some like active driving zone, but there's some correlation with the isolated rate potential during sinus rhythm. So what's explanation the isolated rate potential more likely associate the active driving activity during a VF? Why you overlap it? As well, it's not big macro oriented, more likely rotation activity.
Right.
Do you need the potential for to make a rotation activity, like an explanation?
Yeah, it's a good question. If you think to something like ischemic VT, you need a kind of abnormal electrograms. More to make it VT, you need to drive the impulse. So you need a kind of big isthmus to go through and then to slow down and to give something more regular and sustainable like VT. While when it's ventricular fibrillation, it's a kind of island, just island, not enough to slow down the re-entry water driver, call it whatever you want. Not enough to slow down, but enough to disorganize the impulse and create more VF, something disorganized than VT. It's the way I see. It's kind of patchy, abnormal electrograms, and I don't call it even isthmus. It's really a kind of isolated island.
The average age of long QT syndrome patient in Milano, the ablated, is about 40 years of age, but it's many years after setting the diagnosis. So does it take some time to develop the structure changes?
Yeah, probably. We don't know yet. We are still far to know absolutely everything. It might be just the beginning. It might be that we are much earlier from the disease. And you can see, if you look at the spectrum, there is a nice picture from Visser in 2015. It's a kind of pyramid showing the beginning of idiopathic ventricular fibrillation. The base was quite large. We were more than 10%. But as the technology evolved, imaging, genetics, and whatever, you go to the top of the pyramid and you find diagnosis for idiopathic ventricular fibrillation, whether it's genetics, DPP6, other mutation that explain this. So what I want to say is we are really at the early stage of something, of a cardiomyopathy. Definitely.
Okay, thank you. So are there other questions?
Okay, we have a few minutes. Again, Dr. Chikonte is offline, but surprisingly, long QT syndrome after ablating, RV epicardia or LV epicardia, is QT normalized? Is that consistent data, or what a QT we are looking for last 40 years? Prolonged QT interval ablating epicardially normalized? It's a very interesting. If that's very consistent, then we got to change the concept of measuring a QT interval.
But I think we need to be cautious whether it is concomitant that you found these abnormal electrograms or it is really directly linked to the QT. We know that you have a lot of innervation on the epicardial. When you ablate, you also affect the nervous system. Yeah. So I'm not surprised that actually the heart rate increased, therefore the QT reduced. And there have been already case report, I think it's 2 or 3, that has been published 4-5 years ago, saying that even doing ablation of some area in the atria actually could reduce QT interval.
Okay. So that's
could reduce also QT interval, and like it was 2 patients with 2 QT that had VF. So
more like a denabation effects, not directly myocardial ablation.
Probably, but we need more data to really link these two findings.
Okay. So thank you, Hiroshi, and we change sharing before live transmission. Okay. Thank you.
Okay. Thank you.